everyone. I'm Mohsin Maqbool. I welcome you all on behalf of the Pediatric Sleep Institute, which is the department of Texas Health Center for Diagnostics and Surgery. Please feel free to have refreshments during the conference and feel free to ask any questions at the end of presentations. Pediatric Sleep Institute is a standalone, dedicated pediatric sleep lab that offers EEG and sleep study facility to children from 6 to 18 months of age. Our first topic is sleep disordered breathing in children, which is the most commonly encountered clinical situation in my clinical practice. And I will start by introducing you to the field of pediatric sleep medicine itself. It's a relatively new field. It just sprung in the past 10 years. There are very few sleep centers. There are fewer sleep specialists, probably because there are only 2 fellowship programs in the country. They're both run by pediatric neurology departments in the University of Philadelphia and Harvard Children's. But over the past 10 years, there has been so much expansion in the knowledge about pediatric sleep disorders and its comorbidities that anybody who trained more than 10 years ago and they have not been keeping up with the rapidly changing field, this is going to be a good conference for them. So most commonly asked question in a sleep clinic, actually the second most commonly asked question is, what is a good night's sleep? And the most commonly asked question is, how much sleep do I need? So I don't think that's where the evaluation ends or that's where the answer is, because it's not just the quality or quantity of sleep, it's the quality and also when we get that sleep. A child who presents to a sleep clinic with daytime symptoms or nighttime symptoms, these are the 3 areas that I have to focus on in order to determine if I need to go for a sleep study or how I should proceed with the management of this child. Sleep quantity has been described by National Sleep Foundation. These are the normal ranges of sleep. The one in dark blue is the recommended duration of sleep. The one in light blue is the upper and lower acceptable limits. Then I have kids fill out sleep logs for themselves in order to understand how much they're sleeping. But there comes an age where even parents don't know how much the child is sleeping, in which case we have to use actigraphy, which is a watch that they wear for 2 weeks straight. And when they come back, we're able to see when is their bedtime, when is their wake-up time, and how their sleep schedule is. It's also a good tool to look at sleep quality to some extent. So if you see, underneath every day, right here, are these red markings that indicate movement in sleep. So this is an actigraphy of a child who, in my opinion, was taking too much caffeine. So when we met, I asked him to stop taking caffeine and go back home and try to get better sleep. He comes back and tells me, there were only 2 nights where I took caffeine. And it didn't take me long to tell which 2 nights those were. And on the last night, I even told him that, hey, in the middle of night, that yellow peak, you even use your cell phone for 15 minutes. He was a little freaked out by that. So that's just a tool to assess for sleep quality and sleep quantity. But how do we tell about the quality of sleep? There are several ways by which you can do that. You could assess clinically, ask parents, like how does a child look when they sleep? Do they sleep in a certain posture? Do they sleep upright? Do they sleep with their necks extended? Do they choke, gasp? Do they move, toss and turn all night? Some parents bring audio and video recordings of their children doing things or snoring loudly or stop breathing. And on physical examination in the clinic, if I enter the room and the child is already laying down and kind of napping, it's a sign that there's something going on. And then there are questionnaires. These 3 are the most commonly used adult sleep medicine questionnaires to assess for quality of sleep and quality of wakefulness and fatigue. Pittsburgh Sleep Quality Scale is standardized for adults, not for kids. Epworth Sleepiness Scale, similarly, it is standardized for adults, not for kids. And Fatigue Severity Scale. These are the pediatric sleep questionnaires. They give you some idea about the quality of sleep, quality of wakefulness, quality of school, homework, so forth. The number at the end of every questionnaire is the number of items that are part of that questionnaire. They range from 8 to 140. The one in red is the one that I use most commonly. It's quick, it is standardized, gives me some idea about the quality of sleep in terms of quality of wakefulness, the Pediatric Daytime Sleepiness Scale. It's got 8 points that ask a child how they are doing during the day in terms of wakefulness, alertness, getting tired, and waking up in the morning. So at the end of the day, nothing comes close to the sleep study in terms of determining the actual quality of sleep. And the backbone of a sleep study is an EEG that tells us the quality of sleep. Since its discovery in 1960s, we can now look at EEG and tell which part of sleep a child is in. Wakefulness to drowsy, to non-REM sleep, to REM sleep. And once you record EEG all night and you score every 30-second a given stage of sleep, what you get is a sleep architecture, that skyscraper picture, sleep architecture. It is based on the brain waves. And after its discovery, it was better to understand sleep disturbance in terms of if there are arousals during sleep. Every red arrow is an arousal. Arousal is defined as a definite change on the EEG that you can actually see and mark it. It's a biomarker of a sleep study. In this particular example, the top 2 signals are the EEG. And towards the end, if you see, there's clear disturbance in sleep quality. Before that disturbance, if you follow the last channel, the mic channel, it records the child actually snoring. So you see, with every breath, the child was snoring, and there was a little pause, and there was a snoring sound. So this is an example of an arousal caused by a snoring event or an apneic event. And at the bottom are the waves that tells us the flow and effort. We'll get into more detail about this. So what EEG did, it turned an overnight pulse ox into a sleep study, or a hypnogram as we know it. As the time went by, we came up with new sensors and new signals. So from top to bottom, there's EEG, there are eye movement leads, there's a nasal sensor for flow, a nasal sensor for end-tidal CO2, there's a mic channel, there's abdominal and chest belts to look at movement. We call them effort channels. And the nasal sensor is called the flow channel. There's a pulse ox, there are limb leads, there's EKG. When you combine all of these signals in one view, that's how a sleep study is interpreted from top to bottom. Starting with eye leads to look at rapid eye movements to mark REM sleep, to EEG, chin EMG, snoring mic, limb EEG to look at limb movements, heart rate, oxygen saturation, flow rates and effort, end-tidal CO2, and body position. A sleep study is scored 30 seconds per screen consecutively to get a final view, which is known as the hypnogram. So this is a modern hypnogram that you can see everything happening during sleep in a single view. I call it a radiograph. It's almost like looking at an MRI. Everything is right there. So in this example, if you look at the top one, that's a hypnogram. Red bars in the top one are REM sleep. And if you correlate that REM sleep with oxygen saturation, you see that oxygen saturation in red, it drops every time this child goes into REM sleep. So this child has a REM exacerbated obstructive sleep apnea. That's just one thing to infer from it. So going back to the sleep fragmentation and looking at arousals, what can cause an arousal? Sometimes they're spontaneous, from inner signals, from full bladder, from bowel. In kids with eczema or pain, they can be related to respiratory pauses, obstructive apnea, central apnea, or it could be body movement related or jaw movement related. Could be because of a seizure or an arrhythmia. Sometimes they can be because of acid reflux or effect of medication. Just like sleeping with a full cup of coffee, yeah, people say that I can sleep after taking a full cup of coffee, but your sleep is going to be disturbed and it's going to have a lot of arousals during it. So just to give you an idea of apnea, which literally means no breath, the top 2 channels are the flow channels. known as the nasal and thermiester. Nasal pressure, one looks at the change in pressure of air coming in and out through nose. And the thermiester looks at the temperature. And the bottom one is the effort channel. So based on the lack of flow by at least 90%, we call it an apnea. So for an apnea, the flow has to be diminished by at least 90%. Depending on the presence or lack of effort with an apnea, it could be obstructive or central apnea, respectively. Hypopnea, the most confusing term in sleep medicine for me to help other people understand. But this is hypopnea, the best I can describe it. It's a lack of flow by at least 30% that ends with either a drop in oxygen by 3% or an arousal on the EEG. Either or. They're both hypopneas. RERA, or respiratory effort-related arousal, is a disturbance in sleep due to lack of flow of an event that doesn't meet criteria for an apnea or a hypopnea, but it is definitely a respiratory event leading to disturbance in sleep. So I'm going to name the 4 sleep-disordered breathing conditions here, and you yourself will be able to kind of diagnose in the next slide all 4 of them just based on different indices that we acquire from the sleep study. So the 4 sleep disorders are obstructive sleep apnea and upper airway resistance syndrome. Number 2, central sleep apnea syndrome, sleep-related hypoventilation, and sleep-related hypoxemia. Now, this is the busiest slide of the whole lecture, and this is where all the juice is. So I want your attention. Different indices. First one, AHI, or Obstructive Apnea Hypopnea Index. It is the total number of apneas and hypopneas during the night divided by total sleep time. Any number above 1 is considered sleep apnea, according to American Academy of Sleep Medicine. In our center, we have a cutoff of 2, because 1 is very low. Every child gets diagnosed with sleep apnea. It is very easy for a child to get diagnosed with sleep apnea. All they have to have is 1 event per hour. That number for adults is 5 per hour. After that, they become mild sleep apnea. For children, that number is 1. Our lab has a cutoff of 2. So 2 to 5 is mild, 5 to 10, moderate, over 10, severe, obstructive sleep apnea. Next one is Respiratory Disturbance Index. If you recall the RERA, if a child has a respiratory disturbance leading to an arousal, we count the number of arousals and divide it by the total sleep time to get a frequency per hour. And that's the basis of diagnosis of upper airway resistance syndrome. That's the area of focus of our research. We're trying to present more and more cases like this because they really respond to different modes of treatment, and we'll get into more detail about that. Oxygen desaturation index, the number of times the oxygen saturation drops by 3% per hour. Lowest oxygen saturation during a sleep study. If it stays below 90% for more than 5 minutes at a stretch, that's your diagnostic criteria for sleep-related hypoxemia. And if it drops below 80% during a sleep study, that is linked with high post-op morbidity or mortality. Central apnea index, simple, number of central apneas divided by total sleep time. Any number above 5 is clinically significant. And finally, end-tidal CO2. If it stays above 50 millimeter mercury for more than 25% of total sleep time, that's a diagnostic criteria for sleep-related hypoventilation. So in blue are the 5 sleep-related breathing disorders in a single view with their respiratory indices. So this is the information. Many of them must be ordering sleep studies already. And this is how you read a sleep study based on AHI, oxygen desaturation index, respiratory disturbance index, lowest oxygen saturation, and end-tidal CO2. Based on AASM, or American Academy of Sleep Medicine, criteria for sleep apnea, they have to have at least 1 clinical symptom and 1 PSG, or sleep study feature. A clinical symptom could be snoring, or evidence of sleep disturbance during sleep, or evidence of daytime dysfunction, including hyperactivity or learning problems. And 1 PSG criteria. It could be an AHI of 1 or more, or evidence of hypercarbia, which is end-tidal CO2 more than 50 for more than 25% of time. That's American Academy of Sleep Medicine's definition of pediatric sleep apnea. The American Academy of Pediatrics definition of obstructive sleep apnea, they define it very arbitrarily. They call it a disorder of breathing during sleep characterized by partial or complete obstruction of the airway leading to a disruption in normal ventilation and normal sleep patterns. Sleep apnea, the most common sign or symptom, snoring. Up to 12% of kids snore, but only up to 6% have sleep apnea. So there are way more kids who snore than kids who have sleep apnea. But if a child has sleep apnea and nothing is done for that, chances are, as a grown-up, he's still going to have abnormalities on his sleep study. Pathophysiology is my mentor used to put it this way, it's a plumbing issue. So you just got to fix the plumbing. It has to do with the length and the diameter or radius of the upper airway. The narrower the diameter, the higher the resistance to the power of 4. One is obese child with thick neck and soft tissue around the neck, leading to narrowing of the upper airway. Second, why sleep apnea gets worse during REM sleep is because there is lack of muscle tone during REM sleep, leading to narrowing or upper airway collapse. And then enlarged tonsil and adenoids, they act as a obstruction in the upper airway, reducing the diameter, as shown in this picture. Same child in an upright and recumbent position. And upright, the upper airway is protected. The child is actually breathing consciously. And during sleep, this airway is collapsed, especially during REM sleep. Until 2000 or early 2000s, the concept of pediatric sleep apnea was extrapolated from adult sleep apnea, which was overweight adults with thick neck who would have BMI of more than 30 and would come in with excessive daytime sleepiness and would respond to CPAP. In 2008, David Gozell and colleagues defined a pediatric version of that sleep apnea and called it pediatric sleep apnea type 2, because they would have all the psychological and systemic and metabolic consequences exactly same as adults, with hyperlipidemia, hypertension, increased risk of right heart failure, and so forth. And they described this OSA type 1, a child who's not going to be overweight, who's going to have hyperactivity and attention problems during the day. That child's going to have most likely normal or low body weight. It's going to have tonsils and adenoids, and it's going to respond to that treatment, removal of tonsils and adenoids. And the type 3 obstructive sleep apnea was defined as children with craniofacial abnormalities, starting in the upper left corner, Pfeiffer syndrome, Cruzon syndrome, Hunter syndrome, Golden Haar syndrome, right lower corner, Pierre-Robin sequence before and after mandibulomaxillary advancement surgery, achondroplasia, choanal atresia on the CAT scan, cleft palate, Down syndrome, and Prader-Willi. Over the next 5 to 7 minutes, I'm going to go over the American Academy of Pediatrics guidelines for management and diagnosis of obstructive sleep apnea in children. So first thing, AAP recommends during every well-child visit, you should ask questions about snoring. If the child snores, ask more questions. If they have any evidence of sleep disturbance or wakefulness disturbance during the day, first step is to do a sleep study, or they call it a gold standard. The evidence quality of this guideline is evidence quality A, which means after meta-analysis of a lot of studies, this ended up being the gold standard. Another option is to refer the child to a sleep specialist or an ENT. A sleep specialist is defined as a pediatrician or a pediatric subspecialist who has experience and or training in treating children with sleep disorders. And if sleep study is not available, you could use an overnight pulse ox or video recordings or audio recordings just to get an idea about the sleep disturbance at night. So I'm going to expand a little bit on this referral process, or it's a recommendation about referral to sleep specialist versus an ENT. Because according to the guidelines by American Academy of Otolaryngology and Head and Neck Surgery, they are going to do a sleep study as an ENT in a child who's high risk, who's obese, hypotonic, has neuromuscular disorder, or mucopolysaccharidosis. But for every other child, if it's a clear-cut case, enlarged tonsils, history of sleep disturbance, a sleep study is not really pushed for. They can still go ahead and operate the child. So that's the main difference between how a pediatric subspecialist is going to manage that child by doing sleep study in all children versus an ENT where they will go ahead and treat a child where there's high index of clinical suspicion that taking the tonsils out is going to treat their sleep apnea. Next step, take the tonsils out if the child has sleep apnea, if they meet criteria. High-risk cases with severe sleep apnea or extreme obesity, they should be monitored post-operatively. And 6 to 8 weeks after upper airway surgery, reassess them. And the kids with high AHI or severe sleep apnea, even after upper airway surgery, are going to have some degree of upper airway resistance and sleep apnea, even post-operatively. So to reassess those, a repeat sleep study is suggested if they meet the clinical criteria. Key action statements 6, 7, and 8 revolve around CPAP, weight loss, and using nasal corticosteroids to help with nasal breathing. How does sleep apnea cause brain injury? 3 mechanisms. Intermittent hypoxia leads to inflammation, systemic and local. Sleep fragmentation leads to frontal lobe signs, aka executive dysfunction or symptoms of ADHD in children. And hypercarbia only worsens the brain injury caused by hypoxemia. There are several studies that looked at gray matter loss in individuals with sleep apnea. And if you see the area of brain loss or gray matter loss in the brain is mostly concentrated around frontal lobes. That's where the executive functions are. That's where the symptoms of ADHD arise. Another study using diffusion tensor imaging, medial frontal lobe and cingulum. Several studies looking at neuropsychological profile of children with sleep apnea have been done, and they have all found a lower IQ and symptoms consistent with executive deficit or ADHD. In a recent study in 2016 came out of Brazil that compared upper airway resistance syndrome with mild obstructive sleep apnea and found that kids with upper airway resistance syndrome have worse quality of sleep compared with sleep apnea. A quick word about home sleep apnea testing. As of last year, it's not recommended in children. So in summary, there's a strong association between pediatric sleep disorders and their neurocognitive symptoms. Please do screen children for snoring and sleep disturbance and ask follow-up questions about sleep disturbance. Keep a low threshold for ordering sleep studies for children who have hypotonia or craniofacial abnormalities. PSG or sleep study is a gold standard for diagnosing sleep disordered breathing. There is no universal treatment for OSA. It's a team approach, as today we are going to accomplish that goal. And it's an algorithm. Not every child is a candidate for TNA. Not every child who has TNA is going to outgrow or be treated for sleep apnea. Sometimes it takes a dentist to help a child. Sometimes it takes an orthodontist to help a child. Unfortunately, no such guidelines exist at this time. As we reviewed all the guidelines, I didn't hear the word dentist or orthodontist in the whole algorithm or the flow sheet. I think there has to be more involvement and more intercollegial talks and policy making in future. This conference was a little attempt to accomplish that, because being a sleep doctor, I have attended sleep conferences, but I've never seen a dentist, an orthodontist, an ENT doctor, and sleep doctors present in the same room. So this was one of the attempts to enhance that intercollegial collaboration. That's the end of my talk.